Welcome back to the Deep Dive. Today, we are undertaking a critical, focused mission, and it's tailor-made for those of you currently preparing for the rigorous MD anesthesia exams. Specifically, we're anticipating what the faculty at Gujarat University really expects you to know. We are cracking open a cornerstone of modern intravenous anesthesia, ketamine.
This is absolutely a high-stakes review. Ketamine is not just another drug, it's a foundational concept. Understanding it really demonstrates your comprehensive grasp of both basic pharmacology and, more importantly, applied critical care.
Right.
Our goal today is to synthesize all this vast material into exam-ready insights. We're talking about the subtle nuances, the controversial points, and the precise definitions that will differentiate a top theory paper from an average one.
And, of course, secure success in the Viva.
Exactly. The Viva is where these details matter most.
We know you've all read the textbooks, but we're going to go deeper. We have structured this deep dive to cover everything systematically, from the molecular chemistry of, say, the clinically superior S+ isomer, all the way up to the modern controversies around its use in trauma in neuroanesthesia. So think of this as your personalized, high-yield audio guide.
And it's designed for repeated, focused listening. That's how you'll solidify these complex, non-negotiable facts.
Okay, let's start exactly where the examiner will start: definition and classification. If that first question is a comprehensive overview of ketamine, how should you frame your answer?
You absolutely must approach it from three angles. You can't just give one definition.
Okay.
So you have chemical, pharmacological, and clinical. Chemically, you immediately classify ketamine as a phencyclidine derivative.
That's PCP. Right.
This is a structural analog of phencyclidine, or PCP, which is a known drug of abuse. You have to mention that connection.
Does the potency compare?
Thankfully, ketamine is about 1/10 as potent in producing those hallucinogenic effects, so it's much more controlled.
Good. Okay, so that's chemical. What's the pharmacological classification?
Pharmacologically, we classify it as a non-gamma aminobutyric acid sedative and hypnotic agent. It's important to state it's not working on GABA, unlike most other agents.
And that's its key distinction.
It is, but its true distinction comes clinically, where it's simply classified as a unique intravenous anesthetic.
That unique clinical classification leads us right to the core concept, the one you have to define for any exam: dissociative anesthesia. What's the precise academic definition of that state?
Okay, so dissociative anesthesia is a cataleptic state.
Cataleptic. What does that mean in simple terms?
It means the patient is in a trance-like state. It's characterized by four primary features you should list: profound analgesia, immobility, amnesia, and a light sleep state.
And the clinical picture is very striking, isn't it?
It's perhaps the most striking aspect, and you should be ready to describe this vividly. The patient appears to be awake.
Their eyes are open.
Often their eyes are open, sometimes with a slow side-to-side, neloismic gaze. But, and this is crucial, they are non-communicative and appear utterly unable to process or respond appropriately to sensory stimuli.
Right. They look like they're there, but they're not. And what about that classic textbook fact we always learn, the preservation of reflexes?
Yes. The clinical dogma states that protective airway reflexes, so cough, swallowing, and corneal reflexes, are preserved. This is a point of distinction from, say, volatile agents or standard GABAergic intravenous agents.
But there's a huge caveat here, isn't there?
A massive one. And you must caution the examiner that preserved does not equate to protected.
Okay. Explain that distinction.
Well, while the reflex arc itself remains active, the coordination and the efficacy of that protection might be diminished. So what that really means is that silent aspiration remains a significant risk, especially in the full stomach patient. You can't rely on it.
Let's connect that clinical appearance back to the underlying physiology. So how do we explain the mechanism of this dissociation? What is functionally separating here?
The mechanism is a functional separation or disorganization right within the central nervous system. Ketamine works by selectively depressing neuronal function in the thalamocortical tract,
which is the brain's main sensory highway.
Exactly. It relays sensory information from the periphery up to the cortex for processing. But at the same time, it stimulates key areas of the limbic system.
Like the hippocampus.
The hippocampus, parts of the cingulate gyrus, areas involved in emotion, memory, and spatial awareness.
So you're shutting down the input but revving up the emotion and memory centers.
And that unequal modulation, depressing the incoming sensory flow while stimulating the emotional centers, causes the patient to be functionally disconnected or dissociated from their awareness of pain and their environment.
So despite being one of the older intravenous agents, ketamine remains absolutely vital in modern practice. If you're asked for its continued clinical importance, what are the three big unique advantages that keep it in use?
You need to be able to state these 3 points quickly and clearly. First, its unique hemodynamic profile. It causes cardiovascular stimulation mainly through sympathomimetic effects. That's almost unique among common induction agents.
And critical in an unstable patient.
Absolutely. Second, its powerful respiratory advantage. It's a potent bronchodilator. This makes it a drug of choice in managing reactive airway disease or even status asthmaticus.
And a third point.
Its extraordinary analgesic power. I mean, this intense analgesia is achieved at sub-anesthetic doses, making it vital for multimodal pain management, for opioid-sparing protocols, and even for treating some chronic pain states.
Understanding how the faculty asks these questions is just as important as knowing the content itself. How should a student anticipate ketamine being posed in the Gujarat University exam?
Well, it's a core agent, so it frequently appears as a comprehensive 10 or 20-mark long answer question. That would require a complete systematic breakdown. Chemistry, MOA, PK, PD, the whole lot.
So the structure we're following today is essentially the required essay outline.
It is. But if you're in the Viva, the questions will get more targeted. They'll focus on the most controversial or nuanced areas.
For example,
You have to be fluent in discussing its use in raised ICP and how you'd mitigate that effect, and its paradoxical use in shock.
you mean the difference between hypovolemic shock and septic shock?
Exactly. The distinction between its stimulating effects and volume loss versus its potential to cause collapse in severe septic shock, where catecholamine stores are depleted. These are the non-negotiable nuances for a passing grade.
That rapid functional dissociation is a consequence of its core chemistry, which leads us directly into our second section. When the examiner looks at the chemistry section of your paper, what are the two high-yield pieces of knowledge they're testing for?
Okay, so first is its relationship to phencyclidine, which we've mentioned. But the truly critical concept here is chirality.
Chirality, the idea of mirror image molecule.
Exactly. Ketamine has a chiral center, meaning it can exist as two mirror image isomers or enantiomers. The standard commercial preparation you find is a racemic mixture,
Which is an equal mix.
a 50-50 mix of the S plus and the R isomers.
Right. We often hear about S plus ketamine or esketamine being clinically superior. If the question asks for the advantages of using the isolated S plus isomer, what specific facts do we need to provide?
Well, the S plus isomer is pharmacologically and clinically superior because it demonstrates a much, much greater affinity for that NMDA receptor binding site.
And what does that translate to clinically?
It translates into it being approximately 2 to 4 times more potent as an anesthetic and an analgesic than the R form.
So you use a lower dose for the same effect.
Precisely. And just as importantly, the S plus form is also associated with a faster clearance and recovery phase, and significantly fewer of those psychomimetic side effects and less troublesome salivation.
That makes the R isomer sound almost detrimental. Is there specific evidence of harm related to that R form?
Yes, and mentioning this really shows a depth of knowledge. The R isomer has been shown in some studies to potentially block certain cardioprotective effects, like ischemic preconditioning.
So it's not just inert, it could be actively unhelpful.
It could be. Furthermore, because it's a less potent binder, it acts as a partial competitive agonist in some contexts. This might actually inhibit the metabolism and clearance of the clinically superior S plus form, thereby prolonging the recovery phase.
So using the isolated S plus form just eliminates all those negative interference effects.
That's the idea.
Okay, let's address formulation now. Ketamine is remarkably versatile in its administration routes.
It is. It's available as ketamine hydrochloride in several concentrations, 1%, 5%, and 10% solutions.
That's 10, 50, or 100 mg per liter.
Correct. And this variability allows for both low-volume YV induction and the higher volume IM administration needed in some cases.
What about its physicochemical traits? What are the key numbers to remember?
You must know it is highly lipid soluble, a staggering 5 to 19 times more soluble than thiopentone, and it has a pK of 7.5.
Meaning at body pH, a lot of it is non-ionized.
A substantial fraction remains non-ionized, which facilitates that rapid passage across membranes, like the blood-brain barrier.
That high lipid solubility is the key to its rapid action, which we'll get to in the PK section. But first, let's discuss the critical exam point about stability and storage, specifically concerning preservative-free solutions.
This is a Viva safety question that frequently traps students. You have to be ready for it. The preservative used in the standard racemic commercial preparation is benzethonium chloride.
And what's the problem with that?
The problem is that benzethonium chloride is neurotoxic.
Right. So if the question involves neuraxial administration,
You must state unequivocally that only preservative-free solutions can be used. If you're talking about epidural or intrathecal use, this is a non-negotiable safety point.
and those are typically only the S plus isomer preparations.
Generally, yes. The purified S plus isomer preparations are available in a preservative-free form suitable for intrathecal or epidural injection. Failure to specify preservative-free status when discussing neuraxial use is a critical safety error in an exam.
Okay, let's unpack this. If you're writing a 20-mark answer, the mechanism of action should occupy a substantial portion of your content. It really explains the entire clinical profile. So here's where it gets really interesting. The primary molecular target.
The primary target and the absolute core knowledge point is the N-methyl-D-aspartate receptor, or NMDA receptor.
And ketamine's action on it.
Ketamine is categorized as a non-competitive antagonist of this receptor. The NMDA receptor itself is a ligand-gated ion channel that's selective for calcium ions.
And its main job is to respond to glutamate.
Exactly. Its primary endogenous excitatory neurotransmitter is glutamate.
So what does non-competitive antagonism mean in practical terms for how it works on the receptor?
Well, it means ketamine doesn't compete with glutamate for that initial binding site on the exterior of the cell.
It doesn't fight for the same spot.
No. Instead, ketamine binds to a specific location within the open ion channel itself. This is known as the Phencyclidine recognition site.
So it gets inside the channel?
It does. And when it binds there, it acts like a physical plug. It physically blocks the passage of calcium ions, irrespective of whether glutamate is bound to the external receptor site or not.
And by blocking that calcium influx, it shuts down the whole pathway.
It effectively inhibits the primary excitatory neurotransmitter pathway, glutamate, which leads to that central depression and the loss of sensory processing.
And this action is what drives those central effects we talked about, the differential modulation of brain structures that leads to the dissociative state.
Exactly. As we noted, ketamine selectively depresses neuronal function in the cortex, especially the association areas, and the thalamus, that major sensory relay station.
But at the same time, it's stimulating other areas.
Right. Simultaneously, it stimulates parts of the limbic system, particularly the hippocampus, leading to those bizarre subjective experiences and the preservation of some reflexes. The EEG actually corroborates this. You see a shift towards generalized CNS excitatory patterns, specifically theta wave activity.
So the functional dissociation is essentially the result of the brain's input highway being shut down, the thalamocortical tract inhibition, while the emotional and memory processing center, the limbic system, remains highly active or even stimulated.
That is the precise mechanism you must articulate. It is a functional disorganization, not global depression. The brain is receiving conflicting signals, and the sensory input is filtered out and misinterpreted.
Let's shift to its analgesic properties at sub-anesthetic doses, which are truly unique. That NMDA antagonism must be key, but where is it acting?
The NMDA antagonism at the spinal cord level, specifically in the dorsal horn, is fundamentally important for its antinociception.
Why is that mechanism so crucial?
It's crucial because it reduces the hyperexcitability phenomenon known as central sensitization or wind-up pain.
Which are hallmarks of chronic pain.
Exactly. These processes are common in chronic pain states and are mediated by persistent NMDA receptor activation. By blocking this, ketamine not only manages existing pain, but can actually prevent the transition from acute to chronic pain.
And that's why it's so powerful in conditions like CRPS and fibromyalgia.
Precisely.
What about its less conventional interactions, like those with opioid receptors? Is it just an NMDA blocker?
No, it's more complex. Its interaction is multifaceted.
Yeah.
It actually acts as an antagonist at mu-opioid receptors, but it's a partial agonist at kappa and delta receptors.
So it's playing on multiple fields.
It is.
Yeah.
And its analgesic profile is boosted even further by monoaminergic effects. It interferes with the reuptake of neurotransmitters like norepinephrine and serotonin, and by doing so, it activates descending inhibitory pain pathways.
You should probably also mention its other minor roles.
For a complete answer, yes. You should also mention its mild local anesthetic properties via voltage-gated sodium channel block and its ability to suppress inflammatory cytokine production, giving it anti-inflammatory effects that contribute to overall pain relief. It's this multi-system interaction that makes its analgesia so profound and so useful for sparing opioids.
Okay, that rapid onset is a direct consequence of the chemistry and distribution. So let's turn our attention to pharmacokinetics, how the body handles ketamine, which is crucial for understanding its clinical duration of action.
The rapid onset is indeed its hallmark. Following an intravenous, or IV, bolus, the onset of anesthesia is lightning fast. You're looking at about 30 to 60 seconds, peaking almost immediately.
And if you can't get an IV?
Well, if IV access isn't established maybe in a pediatric or trauma setting, the intramuscular, or IM, route is used. Here, the onset is delayed to about 2 to 8 minutes, with peak plasma levels hitting around 10 to 15 minutes.
Its versatility allows for other routes too, but with the significant loss of effect due to that hepatic processing.
Precisely. Oral administration suffers from a really high first-pass hepatic metabolism. This results in notoriously poor bioavailability, typically only around 20 to 30%.
Is intranasal any better?
Slightly. Intranasal bioavailability is a bit improved, but still low, around 40 to 50%. That high lipid solubility we mentioned, 5 to 10 times greater than thipental, is what ensures that near instantaneous transfer across the blood-brain barrier. So tell us about the distribution phase. A large volume of distribution, or VD, suggests it spreads out into the peripheral tissues quite extensively. The VD is indeed large, approximately 3 kilograms, and it has very low protein binding, only about 12 to 25%, meaning most of the drug is free to cross the blood-brain barrier.
And there's another factor that speeds up its own delivery to the brain.
Yes, the rapid onset isn't only due to its lipophilicity, it's also the fact that ketamine itself causes increased cerebral blood flow, or CBF. It basically acts as its own self-delivery mechanism. The distribution half-life, the alpha half-life, is extremely rapid, in the range of 11 to 16 minutes.
And this rapid distribution is the key to answering that common Viva question about recovery, isn't it?
You must nail this distinction. Recovery from a single intravenous dose of ketamine is predominantly governed by redistribution.
So from the highly perfused central compartment like the brain
to less perfused peripheral tissues and muscle, it is not driven by elimination or metabolic breakdown, and this contrasts sharply with agents like propofol, where metabolism plays a much more immediate role.
Now let's discuss the metabolism to its active metabolite, norketamine. This is critical for understanding its prolonged effects.
Right. Ketamine is extensively metabolized in the liver. The primary enzyme systems are the cytochrome P450 enzymes, specifically CYP3A4 and CYP2B6.
And the main pathway?
The main metabolic pathway is endomethylation, which converts ketamine to norketamine, also known as metabolite dithers. This is a non-negotiable fact for your exam. You have to know its name.
How potent is norketamine, and why does its existence matter clinically?
Norketamine is pharmacologically active. It retains a significant 20 to 30% of the parent compound's anesthetic potency.
And clinically, what does that mean for the patient?
Clinically, this explains the prolonged effects we see, particularly the extended period of analgesia that persists long after the patient is seemingly awake from the primary anesthetic effect.
I see. And then norketamine gets processed further.
Yes, norketamine is then further processed via hydroxylation and conjugation with glucuronide before it's finally eliminated. It's also vital to note that chronic use of ketamine can induce these P450 enzymes,
leading to tolerance.
Exactly. It leads to increased clearance over time, which explains the observed phenomena of tolerance and even drug dependence in long-term users. The clearance rate is very high, about 1.4 element, which approaches liver blood flow.
And the final exit phase, the elimination?
The elimination half-life, or beta half-life, is in the range of 2 to 3 hours. Excretion occurs primarily in the urine, with the majority as conjugated inactive metabolites. Less than 4% of the unchanged drug is excreted.
So what's the typical duration of anesthesia?
The duration of surgical anesthesia from a single IV dose is typically about 10 to 15 minutes, with full cognitive orientation usually returning within 15 to 30 minutes.
So we've established how the drug gets in and how it's processed. Now let's dissect the effects on the body systems, the pharmacodynamics. This section is where suitability for the critically ill patient is really determined. Let's start with its most distinctive feature, the cardiovascular effects. We describe them as sympathomimetic action?
Yes, and the overall effect is pronounced stimulation, which is crucial. You should be able to list the primary effects. Increases in heart rate, arterial blood pressure, typically a 20 to 40 millimole Hg rise in systolic pressure cardiac output, central venous pressure.
And, as a result, a big increase in the heart's workload.
A significant increase in myocardial oxygen demand and cardiac work.
Yes, that level of stimulation is unusual for an anesthetic.
Yeah.
What are the dual indirect mechanisms driving this powerful central sympathetic outflow?
We teach 2 key mechanisms. First, ketamine centrally stimulates the sympathetic nervous system, increasing the outflow from the CNS. Second, and equal as important, it acts a bit like cocaine. It inhibits the neuronal reuptake of norepinephrine at the peripheral nerve endings.
So it's a double hit, more release and less reuptake.
Exactly. This combination leads to a higher concentration of circulating catecholamines acting on the heart and vasculature, resulting in those observed increases in heart rate and contractility.
Okay, now we have to address the biggest exam trap in the PD section, the biphasic dilemma. The sympathetic stimulation is dominant, but it masks a critical underlying effect.
You must state this explicitly to score high marks. Ketamine possesses a direct negative inotropic effect on the myocardium.
So it's an intrinsic heart muscle depressant.
It is. In a healthy, normovolemic patient with robust, intact endogenous catecholamine stores, the powerful indirect sympathetic stimulation easily overrides and masks this depressant effect. So the net effect is cardiac stimulation.
But the danger arises when those compensatory stores are absent.
Precisely. If you administer ketamine to a critically ill patient who has severely depleted endogenous catecholamine stores, think severe, end-stage septic shock, or prolonged shock states where beta receptors might be chronically downregulated.
The sympathetic stimulation just fails to happen.
It fails to materialize. And in this situation, that direct myocardial depressant effect is unmasked. This can lead to potential, sudden, and profound cardiovascular collapse or a worsening of hypotension.
So it's crucial to emphasize that distinction.
You have to. Ketamine is a circulatory supporter in hypovolemia, but it's a potential depressant in catecholamine-depleted states.
We should also briefly mention its effects on the pulmonary circulation.
Yes, ketamine increases pulmonary artery pressure and vascular resistance, which can be a consideration in patients with pre-existing pulmonary hypertension. It also slightly enhances the arrhythmogenicity of adrenaline, although this is generally not a major clinical concern.
Okay, moving to the respiratory system. The profile here is highly favorable, characterized by minimal central depression.
The key takeaway is minimal depression of the central respiratory drive. The ventilatory response to CO2 is maintained, and any rise in PaCO2 is typically negligible, usually less than 3 mmHg.
Is apnea a risk?
Apnea is rare. It would really only happen if you rapidly inject massive doses IV or if you combine the drug synergistically with other powerful respiratory depressants like high-dose opioids or benzodiazepines.
What makes ketamine so beneficial in the asthmatic patient then?
Its potent bronchodilatory effect.
Yeah.
It is highly effective at reducing airway resistance. The mechanism is multifactorial. It stems from its sympathomimetic property.
Releasing catecholamines?
Yes, and potentiating them, but also its role as a calcium channel blocker and its muscarinic antagonism. This makes it an induction agent of choice in reactive airway disease.
However, the airway reflexes are a source of controversy because of the increased secretions.
Right. Airway reflexes, laryngeal, cough, and swallow are generally preserved, which conceptually helps maintain patency. But we must reiterate that preservation does not equal protection.
The coordination might be off.
The coordination may be disorganized in the dissociative state, and aspiration remains a risk in high-risk patients. The major problem, though, is the increased salivary and tracheobronchial secretions.
Hypersalivation.
This troublesome hypersalivation dramatically increases the risk of laryngospasm and airway obstruction, which is why pretreatment with an antisialagogue like glycopyrrolate is mandatory.
Okay, now for the final highest yield physiological section. The cerebral effects, particularly the entrenched dogma regarding ICP.
Historically, yes, ketamine has been taught as being absolutely contraindicated in neurosurgery or head injury.
Why is that?
Physiologically, it does undeniably increase three critical metrics: cerebral blood flow, CBF, the cerebral metabolic rate, CMRO2, and consequently the intracranial pressure, ICP.
And the increase in CBF is disproportionate, isn't it?
The increase in CBF often outstrips the increase in metabolism, which is what drives that ICP rise.
But the nuance is everything here. What is the sophisticated modern answer to the ICP question that faculty demand in Aviva?
The student must demonstrate that they know the dogma is evolving. You acknowledge the ICP rise, but you immediately follow up by stating that this rise can be effectively blocked or attenuated.
How so?
The rise is largely dependent on the patient's underlying physiological state and their PaCO2. Since ketamine preserves cerebrovascular responsiveness to CO2, two management strategies are key.
Go on.
First, co-administering adjuncts like benzodiazepines, midazolam, or barbiturates like thiopental, which reduce CMRO2 and CBF. And second, using controlled ventilation to reduce PaCO2, which causes cerebral vasoconstriction.
So, with those measures in place,
When those measures are taken, ketamine's utility in critically ill neurotrauma patients, especially those who are hypotensive, is being reevaluated and utilized with success.
lastly, any other system is worth a brief mention for a complete answer.
Ocularly, patients often present with moderate pupil dilation and nystagmus, which can sometimes make it difficult for eye surgery. Musculoskeletal effects include increased skeletal muscle tone, often with coordinated but purposeless movements that can be misinterpreted as seizure activity.
Coagulation.
A minor effect. It can inhibit platelet aggregation via reduction of inositol 1004-first-goal triphosphate formation.
The powerful and unique pharmacodynamic profile of ketamine translates into a very specific set of clinical scenarios where it is the agent of choice. Let's start with its classic role in the induction of anesthesia.
The standard application involves 5E induction at 1 to 2 milligillicummins. However, because of its unique route flexibility, we often rely on IM induction at 4 to 8 milligillikilograms when IV access is challenging.
Especially in an uncooperative pediatric patient.
Exactly, or in adults requiring immediate control where you can't get a line in quickly.
Its profound analgesic properties also make it ideal for procedural sedation, often outside of the main operating theater.
Absolutely, especially in the emergency department, the ED. For short, painful procedures like orthopedic reductions, wound debridement, nerve blocks, or brief endoscopies.
It's perfect.
It is. It's used at a lower dose range, about 0.1 to 0.6 milligillikilograms. It delivers intense analgesia with a minimal risk of critical respiratory depression, making it much safer than relying solely on high-dose opioids.
Okay, now for the classic scenario where ketamine is simply indispensable. Trauma and hypovolemia. This is where you score the highest marks in clinical application.
This is the perfect patient for ketamine. In patients who are hemodynamically unstable, especially those suffering from hemorrhagic shock or profound hypovolemia, ketamine is the agent of choice for rapid sequence induction.
Why?
Its sympathomimetic effects actively support the circulation. It maintains heart rate, blood pressure, and right atrial pressure. This stands in stark contrast to most other induction agents.
Like propofol or barbiturates?
Exactly. Those would cause catastrophic hypotension and cardiovascular collapse in a volume-depleted state.
Does this beneficial effect extend across all types of shocked patients, though?
This is that critical distinction we have to keep making. Yes, it's beneficial in scenarios where the heart requires support, like cardiac tamponade or restrictive pericarditis, where maintaining heart rate and venous return is paramount.
And in early sepsis.
It is also useful in early septic shock. However, we have to apply the caveat. If the patient is in severe protracted septic shock, where their endogenous catecholamine stores are exhausted,
The benefit is lost.
the benefit is lost, and the direct myocardial depressant effect will manifest. This is where clinical judgment is absolutely paramount, and the examiner is testing your ability to weigh those risks.
Its ease of use and safety profile also secure its place in pediatric anesthesia.
Yes, beyond the IM induction for uncooperative children, it's vital in regional techniques. For example, in caudal analgesia, a low dose of about 0.5 milligilligrams is commonly used to significantly prolong the duration of the local anesthetic effect.
And that's through spinal NMDA antagonism.
Correct. And another point is that children statistically have a lower incidence of those unpleasant emergence reactions compared to adults.
The bronchodilatory property makes it the therapeutic agent of last resort for refractory bronchospasm and asthma.
Absolutely. When conventional therapy fails, ketamine is invaluable. It's the agent of choice for induction in patients with reactive airway disease. It has been used successfully in the ICU to treat status asthmaticus refractory to standard beta agonists.
How is it used in that context?
You'd use a loading dose, followed by continuous infusion to sustain bronchodilation, and its efficacy is often equal to that of volatile agents like halothane.
Finally, let's touch on its expanding role in analgesia and ICU sedation.
Its non-opioid, persistent postoperative analgesia is a huge advantage, often maintained at plasma concentrations above 0.1 mg/ml. And it has moved into chronic pain management for conditions that involve central sensitization.
Like neuropathic pain or CRPS?
Neuropathic pain, complex regional pain syndrome, fibromyalgia, phantom limb pain, all of these. In the ICU, its ability to provide effective sedation while maintaining hemodynamics and respiratory drive makes it a very favorable option, frequently combined with benzodiazepines to manage the psychomimetic risk.
To ensure exam readiness, we must be fluent in the crucial dosing regimens. Let's confirm the standard induction doses.
Okay, for standard IV induction, the dose is 1 to 2 mg/kg. If you need supplemental IV doses to prolong the effect, 0.5 mg/kg is a common measure.
Chim for IM.
For IM administration, the dose is substantially higher to account for the slower onset and less efficient absorption. You're looking at 4 to 8 mg/kg, sometimes even cited up to 10 mg/kg.
The shift towards multimodal pain protocols means the analgesic dosing range is equally important to know.
Yes, and the analgesic doses are crucial and must be specified as sub-anesthetic.
Right.
Sub-anesthetic IV doses range from 0.2 to 0.5 mg/kg. For a single intraoperative bolus intended for preventive analgesia, a common practice is around 0.2 mg/kg. This dose gives you the analgesic benefit without inducing full dissociation.
What about the typical rates for continuous infusion in prolonged situations, like ICU sedation or refractory asthma?
For ICU or procedural sedation, the initial bolus is 0.1 to 0.26 mg/kg. Continuous infusion rates can vary widely. For refractory asthma, we typically start low, around 0.15 to 0.25 mg/kg.
And for general ICU sedation?
That can range from 0.2 up to 1 mg/kg, and you'd titrate that to effect.
We should also probably include the antidepressant dose, which is becoming highly relevant in clinical practice.
Yes, that's a great point. The novel antidepressant use is achieved with a very specific low-dose regimen. 0.5 mg/kg administered as a slow infusion over a precisely timed 40 minutes.
So that really demonstrates its therapeutic value lies in careful, slow administration to achieve those sub-anesthetic plasma levels.
Exactly.
And finally, a quick note on actual modifications.
You should always mention that lower doses are mandatory if you're using synergistic adjuvant drugs, particularly midazolam, thiophenol, or inhaled anesthetics, as they will deepen the anesthetic state or potentiate side effects.
And the pediatric coddle dose.
Remember that one, 0.5 mg/kg, and a critical clinical caution. Rapid administration of large bolus doses is strongly discouraged, as it significantly increases the likelihood and severity of adverse psychological emergence reactions.
Okay, so when the examiner asks you to enumerate the advantages of ketamine, and this is a guaranteed 5-mark question, you need a concise, powerful list that really captures its unique niche.
The list is really defined by its ability to support circulation and respiration. That's what sets it apart from the GABA agonists. First, cardiovascular stability.
Right.
The unique sympathomimetic action generally maintains heart rate, blood pressure, and cardiac output, making it the ideal agent for induction in patients who are hypovolemic, in compensated shock, or suffering from conditions like cardiac tamponade.
Second, the respiratory benefits, which are a major safety feature.
Preservation of airway reflexes and ventilatory drive. Minimal central respiratory depression means the patient continues to breathe effectively, and the ventilatory response to CO2 is well maintained.
And those preserved reflexes.
The preserved laryngeal and pharyngeal reflexes, though you have to be cautious, offer a theoretical safety margin over deeply depressing agents.
Third, the profound pain relief.
Potent analgesia. It provides profound, often long-lasting analgesia at sub-anesthetic doses. And crucially, its NMDA antagonism is used to reverse, prevent, and treat both opioid tolerance and hyperalgesia.
Which places it right at the center of modern multimodal analgesia protocols.
Absolutely.
And fourth, its use as a therapeutic bronchodilator.
The bronchodilatory effect. This is an absolute clinical advantage for patients with reactive airway disease. It's capable of managing severe bronchospasm, often equivalent to or even superior to volatile agents, securing its role as the induction agent of choice in asthma.
Every drug has its trade-offs, and ketamine's unique mechanism leads to a very distinct set of adverse effects. This is another area the examiner will probe deeply, particularly the psychological complications. Let's start with emergence reactions.
Right. These are termed psychic emergence phenomena. They manifest as the patient is waking up, typically within the first hour, but the cognitive distortion can linger.
And you need to list the manifestations precisely.
You do. Vivid and brightly colored dreams, which are often reported as having morbid or unpleasant content. Hallucinations. Feelings of confusion, panic, and overwhelming fear.
The most distinctive psychological symptom is that feeling of detachment, correct?
Yes, the extracorporeal experience. That feeling of floating bodily detachment or being outside oneself.
And what's the mechanism behind that?
It's thought to be mechanistically linked to the drug's effect on reducing somatic and proprioceptive sensation. The incidence is substantial in adults, about 10 to 30%, which makes preventative measures mandatory.
Is it the same for all age groups?
The incidence is generally lower in children and the elderly. The mechanism involved that functional disorganization we discussed. The misinterpretation of residual stimuli due to the depression of auditory and visual relay nuclei combined with that overactive limbic system.
Okay, and the airway complications stem directly from one specific side effect.
Increased salivation. This is a highly troublesome and high-risk effect, resulting in increased salivary and tracheobronchial secretions.
And that volume of secretions is the problem.
It can lead to direct airway obstruction, or, critically, it can trigger laryngospasm, especially in children. Therefore, the requirement for mandatory pretreatment with an anti-C oligonucleotide like glycopyrrolate is absolute.
What about the common postoperative issues?
Nausea and vomiting are very commonly reported side effects. And although it's rare, laryngospasm remains a possibility, often linked to those excessive secretions or an over-responsive airway in the semi-awake state.
Any others worth mentioning?
Other noted side effects include transient cortical blindness, altered short-term memory, and increased skeletal muscle tone, which can manifest as those purposeless, rigid movements.
Let's revisit raised intracranial pressure specifically as a complication that requires active management.
While it's a known physiological effect due to the increased CBF and sympathetic response, listing it as a complication requires you to detail the risk. It necessitates extreme caution in patients with space-occupying lesions where there is limited capacity for compensation.
So when you discuss this complication in the exam, you have to immediately pivot to the management strategies.
You must. The mandatory use of adjuncts like benzodiazepines, diazepam, or imidazolum, or barbiturates like thiopental, and utilizing controlled hyperventilation to lower PaSO2, thereby reducing the CDF component of that rise.
Understanding when ketamine is inappropriate demonstrates critical clinical reasoning. So when you're outlining contraindications, we should focus on the potential for that sympathetic stimulation and the CNS effects.
The primary absolute contraindications are all related to that increase in myocardial oxygen demand. Therefore, ketamine is strictly contraindicated in severe ischemic heart disease, uncontrolled systemic hypertension, or the presence of vascular aneurysms, either cerebral or aortic.
Because the sympathetic surge could be catastrophic.
That surge and the resulting tachycardia and increased BP risk ischemia, rupture, or dissection.
And the CNS risks mandate one major relative contraindication.
Raised intracranial pressure. Although its use is being reevaluated, it remains a strong relative contraindication. Its use demands premedication and meticulous PaSO2 management. It is generally avoided in undifferentiated CNS emergencies or confirmed space-occupying lesions until that ICP can be safely controlled.
And given the intense psychomimetic potential, we have to list psychiatric precautions.
You must. Use extreme caution or avoid the drug entirely in patients with pre-existing or poorly managed psychiatric disorders or those with a history of psychotism.
Why is that?
The emergence phenomena could severely complicate their clinical picture, their differential diagnosis, or just their underlying mental state.
Finally, for a complete answer, the examiner is going to expect a list of mandatory clinical precautions, the strategies we use to actively reduce the adverse effects.
This list is critical for the Viva. First, and most effective, premedication with benzodiazepines. Midazolam is preferred for its superior amnesia and quick onset. This is the gold standard for attenuating emergence delirium. Second, premedication with anti-oligonucleotides. Glycopyrrolate is preferred because it doesn't cross the blood-brain barrier as readily as atropine, so it won't exacerbate central confusion.
Okay, what else?
Third, ensuring a quiet, calm recovery environment and minimizing external sensory stimulation during emergence, which might otherwise be misinterpreted by the dissociating brain. And fourth, always avoid the rapid administration of large bolus doses.
The need to mitigate those unwanted side effects has led to the development of highly synergistic and effective combination therapies. This is a very modern and relevant area for the exam. Let's start with the classic pairing, ketamine with benzodiazepines.
The rationale here is simple compensation. Benzodiazepines like midazolam or diazepam are powerful sedatives and amnestics. They effectively attenuate the unwanted psychological reactions.
The emergence delirium.
Exactly, and they simultaneously provide sedation. Furthermore, they help blunt the cardiovascular stimulatory effects of ketamine, leading to a smoother overall profile.
And midazolam is usually the one you'd choose.
Generally, yes. It's often favored due to its excellent amnesia and quick action.
Does this combination influence the drug's metabolism at all? Could it prolong its effects?
It can. This is a nuanced pharmacokinetic point that scores well in an exam. Diazepam, specifically, has been shown to prolong ketamine's elimination half-life.
How does it do that?
It partially inhibits the P450 enzyme, specifically CYP3A4, that's responsible for the end-demethylation of ketamine to norketamine.
Interesting. Okay, the most popular combination for total 4 anesthesia or tibia and conscious sedation today is arguably ketofol. Tell us about this blend.
Ketamine with propofol, or ketofol, is increasingly commonplace in operating theaters and ICUs. It's often mixed in a predetermined fixed ratio.
What's the common ratio?
Commonly 1 milligram of ketamine to 10 milligrams of propofol, so a 1 to 10 ratio. Sometimes 1 to 4 ratios are used for specific procedural sedation.
What makes this a pharmacodynamic masterclass? It's a perfect balancing act, right?
It is a beautifully engineered trade-off. Think about it. Propofol is a potent myocardial and respiratory depressant that can cause significant hypotension and respiratory arrest.
And ketamine is a cardiac stimulant that causes psychomimetic effects.
Right. When you combine them, they effectively cancel out each other's primary flaws. Propofol dramatically blunts the sympathetic stimulation and eliminates the emergence reactions of ketamine. In return, ketamine counteracts propofol's profound cardiorespiratory depression.
So the clinical outcome is superior to either drug alone.
Far superior. You get more stable hemodynamics, reduced ICP compared to ketamine alone, and minimal ventilatory depression compared to propofol alone, often allowing for spontaneous ventilation.
And finally, its combination with opioids in pain management.
Ketamine is used synergistically with opioids for enhanced overall analgesia, but its unique value is preventive. By blocking the NMDA receptors, which are implicated in the development of pain sensitization,
It stops tolerance from developing.
it effectively prevents or reverses opioid tolerance and opioid-induced hyperalgesia. This allows clinicians to achieve better pain control using lower cumulative doses of opioids, which greatly reduces the risk of dependence and side effects.
In the exam, the faculty needs assurance that you can select the right tool for the right job. This means comparing ketamine to its major 5E induction competitors, propofol and etomidate. We need to structure this comparison around clinical suitability.
The comparison must be systematic. When you compare these agents, you should focus on the 3 pillars: hemodynamics, analgesia, and CNS effects.
Okay, let's start with ketamine versus propofol.
On hemodynamics, it's simple. Ketamine is stimulating. It increases heart rate and blood pressure. Propofol is depressing. It decreases blood pressure and systemic vascular resistance.
Analgesia.
Ketamine is profoundly analgesic. Propofol provides none. On airway reflexes, ketamine preserves them. Propofol depresses them, which is why propofol is ideal for LMA insertion.
And on the CNS.
It's a complete opposition. Ketamine increases CBF and ICP. Propofol significantly decreases both CBF and ICP.
So this means ketamine is ideal for the hypertensive, asthmatic, or trauma patient, while propofol is the gold standard for the neurosurgery patient who needs a controlled airway.
Precisely.
Now, ketamine versus etomidate.
Etomidate's primary advantage is its hemodynamic neutrality. Ketamine causes sympathetic stimulation and tachycardia. Etomidate is celebrated for causing minimal hemodynamic change.
So it keeps the heart rate and blood pressure stable.
Very reliably, yes. Primarily because it doesn't really activate or suppress the autonomic nervous system significantly. This makes etomidate the traditional preference for patients with severe coronary artery disease or poor LV function, where you have to avoid any hemodynamic swing.
And what about analgesia and CNS effects?
For analgesia, like propofol, etomidate provides none, while ketamine is powerfully analgesic. On the CNS, ketamine increases CBF and CMRO2. Etomidate significantly decreases both, much like propofol.
And you have to mention etomidate's major side effect.
You absolutely must. Its critical side effect is transient adrenal suppression via 11-beta-hydroxylase inhibition.
So the final exam-oriented comparison point is always a discussion of patient matching.
Absolutely. When you're asked to compare, never just list the effects. Frame your answer around suitability. Ketamine for the hypovolemic, asthmatic, or burn patient. Etomidate for the patient with severe CAD or critical aortic stenosis needing absolute blood pressure stability. And propofol for the patient requiring ICP reduction or a rapid LMA insertion. That demonstrates applied knowledge, not just memorization.
All right, let's rehearse the Viva. The faculty is trying to push you past rote memorization into real clinical understanding. We need to be ready for the curveballs. What are the top 3 frequently asked Viva questions that we must be prepared to answer instantly and confidently?
Okay, first, define dissociative anesthesia and explain the underlying functional dissociation. You have to mention the unequal modulation thalamocortical tract depression coupled with limbic stimulation.
Got it. Number 2.
Second, why must you use an antisialagogue with ketamine? The concise, safe answer is to manage increased salivary and tracheobronchial secretions and prevent the risk of laryngospasm and subsequent airway obstruction.
And number 3.
What is the clinical advantage of S plus ketamine? You must mention higher potency, 2 to 4 times, faster recovery, and fewer psychomimetic side effects.
Okay, and what about the management of ketamine's most feared physiological risks?
They'll ask, how do you manage ketamine-induced rise in ICP? The safe answer, demonstrating modern knowledge, is benzodiazepine co-administration, like with midazolam, and controlled ventilation to reduce PaO2.
And the classic trap question.
Is ketamine safe in septic shock? You have to give the nuanced answer.
Which is?
Yes, if endogenous catecholamine stores are preserved, but caution must be exercised because if those stores are depleted, the drug will unmask its direct myocardial depressant effect, leading to collapse.
Let's run through the common misconceptions, the traps that faculty intentionally lay for you.
Okay, the first trap is assuming ketamine guarantees a protected airway. The safe answer is that reflexes are preserved, but this does not equate to protection against aspiration, especially in the context of a full stomach or high aspiration risk.
So you never promise a protected airway.
Never. Intubation is still often required.
And the cardiac trap.
Stating that ketamine is purely a cardiac stimulant, that shows incomplete knowledge. You must mention the direct negative inotropic effect, which is normally masked but is a dangerous factor in the catecholamine-depleted patient.
And finally, the persistent CNS dogma.
Claiming ketamine is absolutely contraindicated in head injury. The sophisticated answer is, the dogma is being revised because the ICP rise can be safely mitigated by the use of adjuncts and careful ventilatory management. Its use in hemodynamically unstable neurotrauma is now acceptable under controlled conditions.
So the critical takeaway for the Viva is clarity and qualification.
Exactly. Always demonstrate knowledge of the drug's dual physiological nature, stimulation and depression, and always present the management strategy for the adverse effects. Always mention benzos for emergence delirium prevention.
A well-presented theory paper uses structure and illustration to maximize scores. So when you're tackling a comprehensive 20-mark question on ketamine, what simple, high-scoring diagrams should you sketch?
Diagrams break up long text, and they demonstrate a mastery of mechanisms. I'd aim for 3 simple sketches.
Okay, what's the first one?
First, the basic structures of the S+ and R stereoisomers. You just need to draw the basic cyclohexene ring with the chiral carbon marked. That scores points on chemistry.
Simple enough. Second.
A simplified schematic of the NMDA receptor channel. This diagram has to clearly show glutamate and glycine binding on the outside, and, crucially, show ketamine binding non-competitively inside the channel, pore at the Phencyclidine site, to physically block the calcium passage.
Right, showing that plug-in-a-drain concept. And the third diagram.
The primary metabolic pathway. Just an arrow showing ketamine to norketamine to conjugates. Very simple, but very effective.
And how should a student allocate their writing space and structure the comprehensive 20-mark answer to meet faculty expectations?
You need a clear, systematic flow. You must use the mandated headings. The mechanism of action and the pharmacodynamics, especially the cardiovascular and cerebral effects, should be the most detailed. They should take up roughly 40 to 50% of your space.
Because that's where the real complexity lies.
Exactly. And your clinical uses must be targeted and case-based. Don't just list them.
Let's confirm the mandatory headings that examiners expect for a full, complete answer on this topic.
The structure must be 1. Introduction, definition, classification, dissociative anesthesia. 2. Chemistry, RVSS, isomer, Neuraxial safety. 3. Mechanism of action, the NMDA antagonism and central limbic dissociation.
Keep going.
4. Pharmacokinetics, redistribution versus elimination norketamine. V. Pharmacodynamics, system-wise, focusing on that masked depression. 6. Clinical uses, trauma, asthma, pediatrics. 7. Advantages and combinations, ketofol. 8. Adverse effects and management, emergence and salivation. And finally, 9X, contraindications. Stick rigidly to that blueprint.
We've covered a tremendous amount of ground. For the final rapid-fire preparation phase, let's solidify the top 12 must-know facts, the absolute core of ketamine knowledge for the exam.
This is your final checklist. 1. Ketamine is a phencyclidine derivative causing dissociative anesthesia, a cataleptic state.
2.
2. Primary MOA is non-competitive NMDA receptor antagonism, blocking calcium influx within the channel.
3.
3. The S+ isomer is 2 to 4 times more potent with faster recovery and fewer psychological side effects.
4.
4. Recovery from a single dose is mainly due to rapid redistribution from the brain. That alpha half-life is about 11 minutes.
5.
The active metabolite is norketamine, which retains 20 to 30% potency and contributes to prolonged analgesia. 6. Cardiovascular effects are due to central sympathetic stimulation. a cocaine-like effect, increasing heart rate and blood pressure.
7. The critical nuance.
7. The critical nuance is that direct myocardial depression is unmasked in catecholamine-depleted shock, like severe sepsis.
8.
8. It is a potent bronchodilator, making it the agent of choice for asthma and bronchospasm.
9.
9. It increases CBF, CMRO2, and ICP.
10.
10. Emergence reactions are common, 10 to 30% in adults, and are most effectively preventable with benzodiazepines.
11.
11. Antisialagogues like glycopyrrolate are mandatory to manage secretions and prevent laryngospasm.
And finally, 12.
12. It reverses and prevents opioid tolerance and hyperalgesia via NMDA antagonism.
That list provides an exceptional mental blueprint for the final days of study. Now, if a student is concluding their 20-mark essay, they need a paragraph that brings all this complexity together elegantly.
A strong conclusion demonstrates a synthesis of knowledge. It has to acknowledge both the benefits and the necessary precautions. I'd suggest using this model. Ketamine remains an indispensable agent in modern anesthesiology, uniquely positioned due to its combination of profound analgesia, bronchodilatory properties, and general cardiovascular stability in the normovolemic patient.
So start with the positives.
Yes, then add the balance. While its distinct pharmacodynamic profile necessitates meticulous management of central nervous system and psychological side effects, primarily achieved through judicious combination with adjuncts like benzodiazepines or propofol, its utility in high-risk patients, particularly those with trauma, shock, or reactive airway disease, secures its continued importance in clinical practice and as a high-yield topic for examination success.
That powerful summary captures the duality of ketamine perfectly. It truly is a drug where the risks and the rewards are constantly balanced, demanding sophisticated clinical judgment. The ultimate lesson of ketamine, I think, is that dogma must always be challenged by current evidence. You can't just assume knowledge about an agent is static. The fact that we now use ketamine safely in controlled neuroanesthesia settings shows how smart use of adjuncts can completely redefine the limitations of a core drug.
When you're reviewing this material, visualize the specific clinical scenarios. Picture the trauma induction where the blood pressure is falling. See the patient in status asthmaticus who is refractory to nebulizers, or the patient receiving a ketofol infusion in the ICU. Connecting the precise pharmacology to the immediate clinical benefit or risk is the final step to truly mastering this drug for your examination.
Visualize the patient, visualize the effect, and you will nail that viva. We hope this deep dive into ketamine has given you the confidence and the specific high-yield nuggets you need for your exam preparation. Go forth, be nuanced, and conquer that paper. Send us your next set of sources, and we will prepare your next deep dive. Until next time.